pressure, that negative pleural pressure, and it collapses the whole lung. And that's what we really see last time. And what was the cardiovascular effect? Cardiovascular effect was, when we talk about this lung, we talk about the heart. The heart is over here. So in case of heart, the right atrium, from the top, there goes the superior vena cava, and from here is the inferior vena cava. Now, these superior vena cava and inferior vena cava, they are quite thin. So, because of the pressure, when they are compressed, right, when they are compressed, so there will be some important sign symptoms. Yeah, one email was that which vena cava would be more compressed. Well, it would be the superior vena cava. Okay? Superior vena cava. Reason? Over here there is diaphragm. So when we see that it is only a very small portion of inferior vena cava which is actually into the most of the entire inferior vena cava, IVC. This IVC, it is into the abdomen, right? And that's the reason that the impact on inferior vena cava would be less. But well, there are certain conditions in which even the inferior vena cava would be involved. So we'll see that thing when we'll be talking about the cardiology. But looking at this, it would be the superior vena cava. Now, when the superior vena cava is compressed, we saw that it is formed by that brachiocephalic trunk, right? And these brachiocephalic trunk, these are in which the jugular vein, external and internal jugular vein, they were draining. So when this path is compressed, so there will be the complete back pressure. That's the reason there will be neck vein engorgement. Right? Neck veins are seen very prominently. And there is a rise in the internal jugular, or it is called as the jugular venous pressure, JV, jugular venous pressure. Right? It is but obvious, the blood which is trying to go, and if you block the path, right, it is same like a traffic. The road is blocked. What about the traffic which is constantly coming? So when they are coming, so obviously this entire road will be blocked. Okay, so the time is 10:35 and it's time we start with our today's topic. Again, area of focus will remain the same, the pleura. But this time, instead of air, there will be fluid in it. Okay. For those who have joined recently or present, all those lectures when we discussed about the pleura, we'll discuss something something very quickly. But this would be the foundation. Don't worry about if you are not attending this lecture. So here is the lung. Here is the lung, and literally the way we have got those pillows, right? We have got the pillow, and then there is a pillow cover. Correct? There is a pillow cover. Just consider that pleura is exactly like that. So there is a covering. This covering, it is for the entire. We are drawing just this much, but as such, it's all the way. When at the hilum, hilum is that area from where the bronchus, primary bronchus, it will be entering from where the bronchial vessels, pulmonary vessels, right? They will be entering and leaving. So that is the hilum, and this is how this entire lung is literally packed. Both the lungs, right? We are just drawing one lung. This is the right side, but it is literally packed in both sides. So here is the lung. Over here, this one, that is our chest wall, right? So you can say that these are the cut end of the ribs. So this and this. If we really zoom it slightly, so here is the lung tissue. Then this is a layer. This is the chest wall. Correct? This is the chest wall. This is the lung. So lining which is present over here, this one, it is called as the visceral pleura. Visceral pleura. Viscera means organ. So lung is one of the organ. So that's why visceral pleura. And this is the outer pleura. It is also called as the parietal pleura. So it is this space which is present in between. That is the space in which we are interested. It is this space. Now, when we say that pleural effusion means fluid in the pleural space. And right from the beginning, we are telling that this pleural space is always filled up with fluid. And now we are telling this when it is more than normal. So normally, even if your lungs are so big, right, entire chest cavity is so big, but still the amount of fluid which is present into this pleural space, that is just considering both the lungs, right? It is 10 to 15 ml. That's it. 10 to 15 ml. Hardly 3 teaspoons. 1 teaspoon is about 5 ml. So hardly 3 teaspoons. But that's it. That much fluid is covering the entire lung. So you can imagine that how thin it is. When this fluid increases, right? So it is when it is more than normal, right? Normal like this, more than normal fluid in the pleural space. That is what is called as the pleural effusion. All of you must be having that overhead tank, overhead tank. In the building, there is one tank. So that overhead tank, it overflows. Overhead. Then people shout, "Kare, pani bhar gaya, girta hai pani." That overhead. So, what are the reasons of overflowing? Why should this tank overflow even if it has got this much capacity? Only 2 reasons. One, there is increase in flow. For some reason, the water which is getting pumped into this tank is more, or it is decreased outflow. It means people who are using this water, some the families, they are on vacation, so that's why this tank was not empty, right? So that means anything, it will overflow if there is increase in flow and decrease outflow. How simple, right? Concept is, when we talk about this fluid, well, we cannot revise the whole thing. Try to come in time. We just talked about pleura. We just talked about pleura. Because see, revising the whole thing, that would be like an insult to rest of the 89. Anyway, everything is written over here only. You have not lost much. Remember this part. It is the pleura which we are talking about, and this was the highlight for today. Whenever there is more than normal fluid in the pleural space, and that is the pleural effusion. Pleural effusion is the topic for today. Right? So practically you are not lost anything, but still. And the fluid gets collected when there is increase outflow, the increase in flow, or there is decrease outflow. So easy. Tank, overhead tank kabhi bharti hai when there is more water coming in and less water going out. But this is the principle. When there is so much of rain, so why it happens that the roads, they are all flooded with water? Because the speed at which the water should be exiting, that is less, and the speed at which the water is falling, that is very high. So that's the principle of our diffusion. If you have understood this much, today's topic is easy. The keyword which I was about to write was that the fluid which is present over here in our body, nothing is static. Everything keeps on changing. So the fluid which is into this pleural space, this fluid is dynamic. Otherwise, कहते हैं ना, if the water is stagnant, ना तो सड़ जाता है. Same thing. If this water is static, then it will perish, it will destroy, there will be infection and so many things. This fluid should constantly be rotating. Rotating means new fluid should come and this old fluid should go. So that's the mechanism. Diving deep into it. Now drawing some schematic diagram. Here is the area of focus, and this is pleural space. Correct? So now we'll see everything with respect to pleural space. What is happening? Who is coming in and who is going out? So drawing one more layer, and let's keep over here. These are our lungs. Right? So this is in lungs we have got what? That alveoli, and it is this alveoli where the gas exchange, and with whom it will be doing? With the capillary, right? And because these capillaries, they are related to our respiratory system, so we have given our name pulmonary capillaries. Right? And whatever we discussed till this point of time as the gas exchange, what we were telling, so it is the carbon dioxide which will be given to the alveoli, and the breath which we take, that oxygen, it is given to the pulmonary capillaries. Right? So, pleural spaces between outer and inner layer of lungs will not be telling outer and inner layer of lungs. No. Entire pleural space is totally outside the lungs, not into the lungs. Lungs to यहाँ पे खत्म हो गया. यहाँ पे lungs are over. Right? This is a lung. You know there is a pillow. this होते हैं आराम से. On that there is a pillow cover. This is a pillow cover. Pleura is a pillow cover. Right? So it is completely outside. Right? Good you asked, because otherwise rest of the topic would have been very difficult. Got it? So this is like a pillow. This pillow you consider that this is the lung. Right? The lung. But then when we put a cover around, so that means, can you understand that there would be a gap, there would be a space which will be between the cover and the pillow. Correct? But this is the space which we are now talking about. So, right? So this is the space which we are talking about. Okay. So that's this space. This pleural space. So I am highlighting this, that we always remain, so it remains in sharp focus. All right, things are good. Right? The lungs are there, and this is a pleural space, and we have made things bigger, right? So the pleural space and the outside of the pleural space, right? So over here there are two layers. So can we say this thing as visceral pleura, and things which are outside the pleural space, that is called as the parietal pleura. Parietal pleura. So far, all good. If this much is clear, and rest is all very easy. Parietal pleura. So parietal pleura is, that's where the chest, right, all the muscles and intercostal spaces, etc., they have started coming. Visceral pleura. Viscera means is the organ. That's the lung. In lungs, we know about the alveoli very well. Yes. And there are pulmonary capillaries which will be taking care of the gas exchange. Right? Under normal circumstances, these pulmonary capillaries will not be playing any role in this. Right? So from where the fluid is coming? Well, for the fluid, if I ask you a question, let's see, one rib, second rib. Right? I just highlight this. This is one rib, this is second rib. I want to pass a needle into the thorax. Maybe I want to take a biopsy. So that needle should go at what level? Kahan se jani chahiye? This is the intercostal space. intercostal space. That's right. Okay, let's make it simple. This is 1 or this is 2. From 1 should I pass or from 2? Fantastic. Almost 5, 6, 7, 8. Nice. Nice. So, all right. Everyone has given the correct answer. That's right, because over here at 1 there is vein artery now. Vein artery now. And this intercostal space is quite thin. You can even feel in your own chest, right? What you feel, right? That very tough structure, that is the rib, right? Bone. So you can always feel one bone, feel second bone, and then you will find that, yeah, there is a space, which is relatively soft. So that's soft space. So that is, and then you'll be passing it over here so that you don't damage. This particular vein artery now, they are into intercostal. Now let's call them. So here is that artery. Right? This one. Right? We are drawing it big for our understanding. But let's say we call them intercostal, and they divide. Right? They are called as intercostal microvessels. Simply because of their small size, we call them microvessels. So it is these microvessels, right? They push the fluid into the pleural space. Right? They push the fluid into the pleural space, and then we have amazing system, and that is which takes the fluid out, and that is by pleural lymphatics. In case if there is any confusion for the pleural lymphatics is that system, right, which is like an immune system. It is one fluid which keeps on moving into various channels, and its function is whenever there is infection, right, send a lightning call to the centers that send WBC. Right? So this pleural lymphatics, in fact, that entire lymphatic system, that is what is a part of our immune system. Yeah, I have a doubt from last one before asthma and emphysema occurs. It will always be there. Well, pneumothorax is the first thing to develop because it develops instantly. Right? Then rest of the things. Say for example, asthma. Asthma is what? Asthma is when there is asthmatic attack. Person becomes breathless. Right? But let's say if there is a gunshot, a bullet has entered. Immediately the pleural space is broken. Negative pressure gone, air will enter and immediately it will compress the lungs. Within minutes, you will see the difference. And it is because of that compression, now the person will start becoming breathless. So yeah, pneumothorax is an instant. That's why it is called as the spontaneous pneumothorax, especially the bulla. Right? When the bulla bursts, within no time, you will see that. And that's the reason. Last time we see that chest X-ray, the same patient, right, in which there was a massive pneumothorax. We just put the chest tube, right, with a valve. So with a valve, right, so that the air can go only in one direction. It cannot go back. So within no time, right, the pressure was relieved, and the lungs started expanding. That's the thing. The chest would try to expand, but tell me one thing. Over here, this chest is tough, made up of bones, made up of muscles, intercostal muscle, 3 layers of intercostal muscles, so powerful, right? On top of it, those mammoth muscles, pectoralis major, minor, everyone, right? Back muscles, they are so powerful. And against that poor innocent, which are our lungs so soft, right? So when the air has to expand, obviously it will this will be the soft target, not it will collapse. That's the reason in pneumothorax, you won't find the chest has expanded because air has got not that much of strength to expand the whole chest. When the lung is up, if you compress the lung first. Okay. So coming back to this, so lymphatics is one of the system where all these fluids are drained. So these are the two major mechanisms. So that's why we just write it. This is a major contributor. It is the major contributor. So those vessels, they are important. And this pleural lymphatics, which is taking the fluid out, so that is the major outflow. This one would be the major outflow. So our understanding now becomes much easier. If we want to increase the fluid over here, so either we tell these intercostal microvessels that send more fluid, or if we create one condition in which less fluid is going out. Easy. Right? So either we increase this or we decrease this. But then comes one new thing. These pulmonary capillaries, till now they were like very sharp, aram se, right? They telling that our work is the gaseous exchange. And now this patient has got the high pressure into the pulmonary capillaries. High pressure in the pulmonary capillaries. Why should we fail? It is the heart. It is the heart. That's why today's topic is like a beautiful integration between cardiothoracic cardiology and the respiratory system. See what happens. Here is the heart. Here is a heart. And we are drawing the lung over here. Blood goes. This is right ventricle. Right ventricle, it is taking the deoxygenated blood. So carbon dioxide. It is oxygenated and it is put into the left atrium. And from left ventricle, it would go to the entire body. Right? Via aorta, it would go to the entire body. If I want to increase the pressure over here, what should I do? Don't let the blood go over here. Increase the pressure. So how the pressure can be increased? Well, what if this valve is not open? Mitral stenosis. Mitral stenosis. Stenosed, matlab that valve has become smaller. It is not opening fully. Right? It has narrowed. So that means it will lead to this back pressure. So here there is so much of blood pressure. So when this innocent lung would try to push the blood into the left atrium, won't be able to do it easily. Because there is already, it is a stadium which is full of people. And then when you try to enter into it, so andar ke log aapko bahar dekh. Right? Local trains of Mumbai. Right? The compartment is full. You try to go in. Right? Out. So the pressure, it gets mounted on the platforms. So that pressure is mounted over here. That pressure is mounted over here, right, into the pulmonary capillaries, because from pulmonary capillaries, the blood is going over there. So pressure is mounting over here. Now till this point, when the pressure was normal, things were good. But now the pressure has increased. So that fluid enters into alveoli. That fluid enters into the alveoli, and that gives another next time stopping, what is called as the pulmonary edema. The fluid has started getting collected into the alveoli. Yeah, it is deadly. Obviously, it is deadly. It's dangerous because that alveoli will be useless, because then there will be so much of water. Now, gas exchange won't occur. Sure. Right? What I mean to say in this is, mitral stenosis kya? For any reason. Right? So the mitral stenosis, that was one of the reasons. But what I'm trying to say over here is, the collectively, at least this part is clear. This part is clear that blood will try to go into the left atrium, correct? By the pulmonary veins. These will be the pulmonary veins. Anything happens to this entire circuit, either the pulmonary vein is affected, but pulmonary vein is usually not affected because it has to travel a very short distance. The biggest culprit is this mitral valve. Right? When the mitral valve is narrowed, otherwise if it is normal, so then the blood will easily go from left atrium to left ventricle and life is good. Right? From left ventricle, it goes to the body. It's good. But what if this mitral valve goes out? I mean, it narrows. It is not opening. So instead of entering into the stadium and there are 10 doors, out of that only one door is open. So then entire pressure will be coming on that door. Right? So similarly, there will be back pressure, there will be people on the road. Correct? Same way. What if this is aorta? Correct? From left ventricle, the biggest artery, aorta, goes out. Now there is one valve over here. What if there is aortic stenosis? Again, the same problem, aortic stenosis. Right? What if there is heart attack? And this heart attack in which the left coronary artery, left main coronary artery is involved. Left main coronary artery, which is also called as the widowmaker. Right? Widowmaker. When this is involved, this entire poor left ventricle collapses. So the point is, whether it is the left atrium involved, left ventricle involved, then aortic stenosis or mitral valve, in any case, the blood is not moving. Blood is not moving from left heart to the body. Widow means vidwa. Right? When this left coronary artery, it is occluded, it damages the heart to that extent that person dies. That's why it is called as widowmaker. One of the most dangerous thing which can occur in heart. Anyway, so the point is left heart failure. Collectively, we just write that whenever there is left heart failure, ladki becomes, because this is more common in males. So this is left heart failure. So when there is left heart failure, there is a back pressure, and because of that pressure, there is increased pressure into the pulmonary system, which is called as the pulmonary hypertension. There are two systems now. One is the systemic hypertension. Systemic hypertension, when we measure the blood pressure over here, that is the pressure which is going into the aorta. So that is the blood pressure. For that, people take tablets, right? Systolic, diastolic. But when we discussed about all the pressures, we found that lungs, to this is a very delicate structure. There is no need of that high pressure. Now the pressure has increased because left heart function is not working. It's not okay. Left heart failure. So because of the back pressure, it leads to pulmonary hypertension. And that pulmonary hypertension will put the pressure onto the pulmonary capillaries, because it is this only, these capillaries divide, and one of the capillary is this one, this pulmonary capillary. So here also the blood pressure increases. When the pressure increases, so that these are all very thin endothelium, right? Just single layer of squamous epithelium, single layer. So these cells, they are like bacha. They just can't resist this much pressure. So water gushes into the alveoli. And that leads to what's called as the pulmonary edema. As we'll be progressing more and more, you'll start identifying that, okay, this is the consolidation. This is pulmonary edema. Today, I'll be showing you even the pericardial edema. Pericardial. Right? That is what we see in radiology. A completely new concept. But it is so similar that you will understand in a minute. Now it happens like that for these arteries, it is not so that there is the blood, from the blood, the fluid can go in only one direction. That fluid can go even here. That fluid can go. So this is this is, now there is increased, and this is pathological. This is pathological because normally it should not happen, but now it is happening. Right? So this was the basis of it. This was just the outline of what for our today's discussion. Now let's dive deep. So when we talk about pleural effusion, right, pleural effusion, the definition is more than normal fluid in pleural space. Correct? And normal is how much? 10 to 15 ml total. So in pleural effusion, then there is increased inflow. First, we talked about that was the pleural blood vessels, right? The intercostal vessels. So intercostal vessels, they are normal. It is a normal. That's a major contributor. Intercostal vessels. We talked about. Second, pulmonary capillaries. Pulmonary capillaries under normal circumstances won't be pushing any blood, but that's why in pathological state, that is in case of any disease, pathological states, and in golden capital only, right? Normally it push any blood. What if what is it? No, I'm not getting that. All of fluid. Sometimes some people say that पानी में smell आ रही, and then it is found that वो पानी का पाइप जो था ना, that पानी का पाइप फट गया and बाद में से गटर का पानी अंदर चला गया, the fall sick. Happens. Same thing can happen in the body. This is when say these are the lungs. Over here, yes, that's fine, the trachea, it is getting divided. But then just over there is esophagus also. Esophagus, right? Esophagus, from where we eat. So that esophagus has to travel all the way down. This is the diaphragm, and there it opens into the stomach, correct? What if this esophagus ruptures and then that esophagus pushes the contents into this pleural space? Possible. Similarly, there is another duct, which is one of the lymphatic duct, right? That is the thoracic duct, big one. So thoracic duct, esophagus, they rupture and they push the content into the pleural space. Right? Becomes, yes, both of them, they are serious. Only this thing is normal. Normal. And what about this decreased outflow? Decreased outflow. In one word, lymphatic obstruction. Lymphatic obstruction. So it means, look at this, the lymph which is getting carried out. Is it? What if here is a block? So wash basin mein, there is one space from where the water goes. Wahin pe we put a block. Just a wash basin par jata hai. Same thing. Outflow is blocked. So over here, this lymphatic obstruction, it is common in cancer, malignancy. In malignancy, we'll see that the lymph nodes, they become bigger. Because lymph node is carrying all the team, all the military to fight out. And because this is a big fight, so that's why lymph node, they become bigger. There are more and more number of cells, right? B cells, they are called as the B cells. B cells. Those B cells, they become plasma cells. Right? Plasma cells, they are the real gundas of achhe gunde, right? For good for our body. And they create those antibodies. Right? And these antibodies, they are dumped into the blood and ki jao, lado, right? But then the phone comes, kare, ye to bahut sare hain. Then they increase the production and they become bigger. In the process, there is, because of compression, because of this, right, the lymph channels, they at times they get blocked because of, not immediately, but a later complication. Cancer in medical terminology is called as the malignancy. So that's why because of malignancy. Many of the malignant cells, many of the cancer cells, they also block these lymphatics. So this is how the pleural effusion can really. Now we look at some of the classical SS sign symptoms. You remember sign and symptoms. Sign, symptoms. Symptoms means what patient tells. The entire katha of patient. पाव भाजी खाई और पराठा खाया और ये खाया और वो खाया, उसके बाद पेट में दर्द हुआ, then उसके बाद ये लिया, right? All that is the patient. When you see, you say that this is the acute symptom, right? So that is what is elicited by and symptoms. They are what patient. Over here, what would happen? Breathlessness. It will occur because the fluid is getting cut. So that fluid will try to compress the lungs. It won't let the lungs work properly. Fluid is more. When the fluid is more, that fluid connection will be more. So then the lungs will be displaced. Because fluid is creating the dadagiri. Fluid is getting cut. So there would be the breathlessness. If this is severe, then and then there would be tracheal deviation. Trachea will be deviated to opposite side, right? Tracheal deviation. A universal principle, just remember in case of chest. That's the lung, that's the heart. This is our trachea, right? That's our trachea. Trachea will be pulled. So deviation of trachea. When you take the X-ray, you see the trachea is shifted on one side. So when there is fibrosis, so trachea will be pulled towards the side of fibrosis. Because fibrosis is what? Fibrosis is when the tissue shrinks. Tissue dies and it shrinks. So it pulls the trachea towards it. And when there is, it is called as the SOL, space occupying lesion. It is called as the space occupying lesion. Lesion means defect, right? So this is where this space occupying lesion. So maybe it is a cancer, and that would push. Then in that case, the trachea will be deviated on the opposite side. Lesion means injury. You can say injury. Or best is disease. Just remember it like this, disease. So it will push it on the opposite side. So over here also, fluid is getting collected. That's why if it is severe, it will be pushed on the opposite side. So for next 5 minutes, now we will be having the class of physics. Then and then we'll be able to understand the reasons behind it. That's why the concept was 2 concepts. Once you have understood, this topic will become so easy. The concept, first concept. This is artery, right? It is like we have zoomed it to multiple levels. This is a very thin arteriole, like last part, and that is when there are just one layer of cells, because we have to go for gaseous exchange, right? So this is when this is happening, oxygen is going, Sun is coming, right? Life is good. Endothelium, right? This is endothelium. And now the pressure rises. Pressure rises. Pressure, only the pressure rises. When the pressure rises, the fluid will be, right? This fluid will be going out from in these spaces, but clear fluid. So the fluid is out. Fluid is out. Because it is a plain fluid, it is called as the transudate. Transudate. Some of the concepts, they are so easy to understand, but if not properly understood, right, वो दिमाग में घूमता रहता है कि यार what he is talking about transudate and exudate. It is that simple. When the fluid is clear, fluid is out, clear fluid. So this is a clear fluid, which is transudate. Right? Remember, transparent, clear fluid. Fluid is transparent, so transudate. Now let's go for another condition. There is infection, massive infection. When there is massive infection, we need to decide. Whenever there is infection, whenever there is inflammation, these endothelial cells, they give space. They shrink. Endothelial shrink. Right? So when the endothelium shrinks, बीच में gap आ गई ना, endothelium shrinks. In case of inflammation, endothelium shrinks. Now, by simple logic, what should really happen? Not only the fluid, right? Fluid तो आएगा ही, but those cells, protein, everyone will start running out, right? Because there is so much of space. Itni सारी space. So all those big cells, so there is fluid, there are blood cells, there is protein, all of them, they are out. They are coming. This is exudate. This is exudate. Clear? So when the transudate can happen in high blood pressure. High blood pressure. So think it like that now you have got a patient who has got pleural effusion. I'll show you all the X-rays, but I want you to think in this way. Patient has got high blood, or let's say we don't know what the patient has got. Your junior comes, you are a senior doctor, the junior comes and in test tube, let's say this patient was having pleural effusion, so we have tapped it. Tap means needle डाल के, right? In the syringe, we have taken some fluid out. And you see that fluid and you tell him or her that what's your diagnosis? Looking at the fluid, everyone would say, ऐसा कैसे पता चला? When you see the fluid is clear, that means it is 100% transudate. When it is transudate, the commonest thing is high blood pressure. It is because of the pressure, right? The fluid has been pushed. Fluid is pushed out. Or it can be because of high blood pressure, so it is easy. It can be because of just discussed left heart failure. Left heart failure. So either the pressure is right from the beginning, or the pressure is getting generated because the destination is blocked. Right? जहाँ पे जाना है वहाँ पे there is block, so that's why it is the back pressure which is mounting. So over here, right? Here is the heart. Right? This is filled from lungs. The blood which was supposed to go over here is unable to go, so that's why the pressure is mounting. So either it is high blood pressure or it is left heart failure, not the right heart. Right heart to must, because if right heart would fail, so sufficient blood won't come. That would be entirely a different topic. And it makes sense, huh? Because if this right heart is not functioning, so then From pulmonary trunk, very less blood would be pushed. There would never be any pressure built up. In fact, lungs will be requesting ke Baba give the blood, right? We need to go for gas exchange. So right heart is telling that I can't give the blood. So then let the patient go breathless. In the patient breathless. Here, because oxygen is not getting the oxygen, right? But that's not the case in this. Here, left heart failure is LHF, left heart failure. So that is what is rising the pressure. So immediately when you see the transudate, be very clear that either it is the left heart failure or it is the high blood pressure. The blood pressure is rising. You see the patient and immediately you will see that if the blood pressure is rising, his face will become red, right? And when it is, and the patient would be restless, high blood pressure. When there is left heart failure, patient would be really inside. Patient won't feel like moving because it is the severe pain which is going. So when there is only dyspnea, when there is only breathlessness, right? Immediately ask if there is any pain, because if there is any pain on the precordium means that area of the heart, right? Area of the chest which is just above the heart. So if there is any pain in the precordium, if that pain is going anywhere, consider that heart is involved. Breathlessness, this is another concept. And you take the X-ray chest and then you find a pleural effusion, confirm, right, that this is going towards the left heart failure. We'll see the cases, right? So why it is said that someone asked that X-ray chest mein kya rakha hai? I like that email. So I don't know whether that gentleman is over here or not, but when it was like X-ray chest mein kya rakha? वही रिप्लाई इट वाज ना कि एक चुटकी सिंदूर की तुम कीमत क्या जानो आई रोट इंस्टेड ऑफ सिंदूर आई रोट एक्सरे चेस्ट वही एक्सरे चेस्ट इज कंसीडर्ड एज the diagnostic thing, easily available, instantly available, and if you're good in the diagnosis, immediately patient's treatment starts. It can. Khushi, good question. Right? And good what you asked. Now that test tube, another case, which is ganda color. It is ganda color. There is some red fluid is also seen. That means this patient is having inflammation. It is the exudate. So that's the importance of transudate and the exudate. Right? So this was the first concept. Concept number 1 for today. Now the second concept. Concept number 2. Again, we are taking this pulmonary. I mean capillary. This is the capillary, and yes, I'm not drawing those endothelium, but just consider that there is this endothelial layer. So that endothelial layer is there. There are two pressures which are working. One, the fluid which is passing through it. The fluid, that pressure is called as the hydrostatic pressure. Hydrostatic pressure. This pressure is always interested in fluid ko bahar bhejo. It push the fluid out. Push the fluid out. This is what is called as the hydrostatic pressure. Hydrostatic means the pressure which is generated on the walls. Hydro means water. That's right. So the pressure which is generated by the fluid on the walls. So if the pressure increases, that fluid will go par, right? Because endothelium, right? In between spaces, we say bhaga par. Right? Right? It's out. That is the hydrostatic pressure. But God has always created the balance. There is one another pressure which loves water. Right? It tells कि नहीं जाने दो. That is called as the oncotic pressure. It is called as the oncotic pressure. Oncotic pressure is also called as the colloid osmotic pressure. Colloid or colloidal osmotic pressure. Osmotic pressure. This pressure is generated in such a way that it loves water. So it will always keep the water with itself. It won't let it go. नहीं जाना, right? So that is the oncotic pressure. Right now you are breathing normally, your body is functioning fine simply because of there is a fine balance between hydrostatic pressure and the oncotic pressure. They are all balanced. Right? So things are good, life is fine. If there is any change in that, you need to know problem. So this oncotic pressure, it is because of protein. How much protein is into the blood? So this oncotic pressure is because of the protein. It is the protein which holds the water. Right? Yeah, just like hydrophobic and hydrophilic. You can say that. Right? So this oncotic pressure, it is generated by the protein. So if there is enough protein, so it will keep the blood, keep the fluid with him. Right? It won't let the fluid out. So now let's see how our pleural effusion comes into picture. Simple, we write it over here. Increased blood pressure. Blood pressure has increased. Left heart failure. So far, all good. Left heart failure. यहाँ तक तो बात समझ. What if someone tells liver failure? Liver failure and your patient gets pleural effusion? Yes. Because protein is formed by the liver. Right? Liver makes protein. Liver makes protein. So when liver is failed, so then protein is not formed. So that's the reason in your patient, the oncotic pressure has dropped. Liver is the main protein manufacturing house of our body. There are many functions of liver. One of the important functions is all the protein, albumin, globulin, all those things, they are made by this liver. That's why दारू पीने से liver खराब होता है, तो it is this. Why it happens? Today we'll be discussing even that also, that why alcohol affects. Simply because it affects the liver. When the liver is affected, that means sufficient protein would be generated. And then it leads to all these problems. Not only this much, when we'll be discussing overall edema, you must have seen that many of the patients, हाथ सूजे हुए हैं, पाँव में इतनी swelling है, all due to this. Oncotic pressure has dropped, right? So now this hydrostatic pressure takes over, and hydrostatic pressure starts pushing the water into the interstitial tissue, right? And then there is swelling, edema, right? Pulmonary edema तो अंदर है, right? वहाँ पे हो रहा है, but there would be edema, even the peripheral edema. Same principles, same principle. That's why once you understand this, the entire concept will change. So liver failure, because liver is making protein. There's no one to make protein. Protein nahi hai, so there is no oncotic pressure. Oncotic pressure nahi hai, so hydrostatic pressure will push the fluid. So this is the one, liver failure. Insufficient diet, someone is not taking protein. So the question sometimes कि कुछ खाते नहीं है, then also how the fluid is getting collected. This is the reason. Those malnourished, it is called as the protein energy malnutrition. Right? It is called as the PEM or the PEM, protein energy malnutrition. Today only I was discussing with one of our friend that why the protein is important. I mean, carbohydrate, it is like a petrol, right? It's like a petrol. If you want to run a marathon, you can't run a marathon without sufficient carbs. That's why pre-preparation, that is tomorrow morning, if let's say I'm running full marathon, so then today, from today, right, I'll start what is called as the carb loading. I'll keep the carbs, I'll start eating slightly more carbs as compared to my routine diet, right? So that khajur, those things which are good carbs, there are bad carbs. One can have that pizza. Pizza has got tons of carbs, but it is all bad carbs. So go for the good carbs. Once it is loaded into the body, your body will utilize those carbs for tomorrow. Yeah, khajur is very good. Right? Dates, right? Dates, yes, it is very good. Muscles will be using that because it is fuel. Carbs means carbohydrate. Sorry. It is called as the carbohydrate. So we have got carbohydrate in our body. Entire body understands only these three things: carbohydrate, protein, and fat. Bas. The entire game, whatever the food which you eat, and the minerals. But minerals we keep it aside. This carbohydrate, it is like a petrol which gives fluid, right? This burning. Fat is like lubrication. It's like a lubricating oil, right? Lubricating oil. Protein is for wear and tear, right? Protein is for wear and tear. Whenever you exercise, there is always micro injury. Aapke muscles break open. But it is the protein which comes and rejoins that. That's the reason why it is said that suppose today you are doing the upper body exercise, then tomorrow don't go for upper body, go for lower. Correct? In gym, in any of the exercise, there is always a resting phase. It is if someone tells कि चलो मैं रोज के 2000 abs मारूं, right? Crunch मारूं. No, he'll go crazy. That this is the reason why it is said there is always a rest day. It is the rest day when you really develop the power, because it is all healing, and for that healing it is the protein which is running. Well, someone runs every day. How much? Once your legs are powerful, so even 5 kilometer run is like a warm-up for you, right? So that's what I'm telling. But someone who has not run in his or her life, 1 kilometer is difficult for them. So that's why it varies. Right? It varies totally. मतलब 2-3 किलोमीटर क्या, 3 किलोमीटर तो कुछ भी नहीं है. मतलब दो you guys are so young, तो 3 किलोमीटर तो वार्म अप भी नहीं है. बात में 3 किलोमीटर चले जाते. हाँ बिंदास 3 किलोमीटर. Stretch marks are those not good. That means you have not given sufficient collagen to your body, and that's why it has given way. And those stretch marks, they don't go easy. For fatty liver, well, start eating lots of green vegetables. Because so many questions have come, I'll interrupt this topic for just a minute, and I'll give you one important tip, something which I'm following rigorously. I wake up at 4 a.m. sharp. It is 4 a.m. sharp. It is not 4:05. It is 4 baje. It's 4:00. Right? From this point till 12 o'clock. The day I'm not doing exercise, it is fine. But on the day when I'm doing exercise, from 4 a.m. to 12 p.m. and दोपहर को 12 बजे तक, no cooked food. Take only veggies and fruits. And this thing, eating window, it has to be 8 onwards, 8 a.m. and window closes at 6 p.m. till sun is there. 6 baje ke baad shutters down. I sleep at 10 o'clock. It is 10 o'clock. 10. All my phones are silent. So then how one gets 8 hours of sleep? It is said that any sleep before 12 o'clock multiplied by 2. So this is 2 into 2. So this sleep would be equivalent to 4 hours. And 12 se 4, right? So that's how 4 plus 4, that is 8 hours. Practically, sleep efficiency is equal to 8 hours. So even by the end of the day, you are equally fresh. Right? There is no strain. The time from 9 o'clock to 10 o'clock, this is the time when I don't watch TV. That is the time for music and studies, etc. So it is multiplied by 2. Its efficiency is so high. Right? That sleep is so good. Don't eat after 7:30 when I am not in my room. And that's okay. start for this morning part also. Till 12 o'clock, don't eat any cooked food. Because after that, your metabolism it slows down. So that's why it starts convert into fat. Gets converted into fat. Many times people say that if you just make that your breakfast, you should be taking breakfast like a king. Right? Your lunch, that should be like a queen, thoda light. And your dinner, it should be like a beggar. एकदम थोड़ा सा. And it makes sense also. गाड़ी जब रोड पे दौड़ना है, नहीं है, तो you make the tank full. We do उल्टा. ब्रेकफास्ट में थोड़ा बहुत जरा सा खा लिया, right? अब पूरे दिन then the car is running, right? And when you want to park it, तब tank full. Dinner, heavy dinner, the biggest mistake. No, nothing. The six nothing. At the most, green tea. At the most, green tea. And sometimes, I love coffee, so it is the black coffee. Okay, so now let's come back to our point. So this is clear. So liver failure, it is one of the things. Protein energy malnutrition, right? That is when the protein is lost. And one of the third condition, which I would like to add, and that is the nephrotic syndrome. Nephrotic syndrome. Nephrotic syndrome means, nephrotic means related to kidney. Yeah, kidney has come into picture. Nephrotic syndrome, it is this. Should I remove this? Let me. Or you remember. Let's do like this, and here I'm writing. In every batch, I said that you being doctor, you should be the most fit person. Because you know all ins and outs, which people are not knowing. So over here, this is the nephrotic syndrome. Nephrotic syndrome is also called as the glomerular nephritis. Now the name only is big, principle is very simple. Here is the Bowman's capsule. This we are talking about the nephron, which is the unit of kidney. So this is the Bowman's capsule. Bowman's capsule. And in this capsule, the arteries, tuft of arteries, the group of arteries, they are going in and they are coiled into this and then they go out. When they are going in and then they are getting accumulated in this small space, so there is pressure which is generated. So that is called as the ultrafiltration. And because of that ultrafiltration, water would be squeezed out of these capillaries and then it will be going all the way to become urine. Well, the entire path is quite long. So some of the electrolytes, they are taken back, right? Say, for example, we don't want that sodium should be lost. We don't want potassium should be lost. So they are taken back. We don't want that person should pass 5 liters of urine in a day. Because kidneys, so they keep on working day night. So that's why even the water will be taken out. And this will be very finely balanced. So that's how it happens. But what if there are in between cells, they are called as the podocytes. They are called as the very interesting name is they are called as the podocyte. Podocyte. These podocytes, they are like filter, right? So some podocytes line pe baithe and then the water is trickling between them. Right? So they act like a filter. What if these cells are damaged? Podocytes are damaged. A finger-like structure, right? So it is like वो अपने चाय बनाने के लिए right वो छानते sieve, right? Sieve, what is called as the sieve, yeah. Right? And then we put that the chai patti remains over here and यहाँ से मस्त chai that goes into the cup, है ना? बस then podocytes are these. These are podocytes. छानने का काम करते. What if this अपनी ये जो sieve है, right? ये टूट गई, इसकी जाली टूट गई. What will happen? इतनी भी अच्छी चाय बनाए, all everything, right? Right? Everything will keep on going. हाँ, छन्नी, right? Everything will start going into the tea, right? अब वो चाय कैसे बनेगी? एकदम बेकार. Here it happens. ये छलनी टूट गई. These podocytes broken. That's right, Anand. Wonderful. Protein will be going into the urine, and that is what is called as the proteinuria, right? The protein, जो protein is a big molecule. तो ये protein तो कोई जाने ही ना दे, right? Big molecule. तो protein यहाँ से गए, but no one allowed them to go into the urine और यहाँ से वापस. But now because of this glomerulonephritis, itis means inflammation, right? Inflammation. So all those podocytes destroyed. Dham, protein has gone, and that has led to proteinuria. So protein in urine, and that's why whenever you see the blood report and the urine report, you see that presence of protein, presence of albumin. Right? To be specific, this is albumin. Albumin is the main protein. So it is also called as the albuminuria. This albumin is going into the urine. So when you say albumin plus into the urine, immediately you know that liver, that the kidneys, there is some problem in the kidneys. Right? Even this one. So over here, body understands that it was protein gaya, protein lost. The moment protein is lost, it is lost from the body. So that means there would be decreased oncotic pressure. Upper, right, into the pulmonary capillaries. Kahan pe? Yahan pe. There is decreased oncotic pressure. Decrease on oncotic pressure can't hold the water. Oh, that water, it goes here. That water, it goes into the and it leads to pleural. So when you see the X-ray chest, all these things should run in the mind. When you say that, okay, X-ray chest done, there is massive pleural effusion, immediately you will tell your resident doctor, isko bhejo ultrasound. And radiologist se baat kar. So when you are a radiologist, the responsibility is so high because you need to not only understand this, but at the same time, you say that yes, liver is affected. There is cirrhosis of liver. Cirrhosis of liver gone, right? That means the liver is affected. But then you will just watch the kidneys also. Is there any hydronephrosis? Are the kidneys of normal size, shape, parenchyma is normal? If not, now you are knowing that even the kidneys are affected. So you will tell your friend you'll call in the medicine unit that these are the things which I see, and you treat accordingly. So then the treatment changes, right? So sometimes they say कि X-ray देखा and ultrasound का खर्चा. Yes, people tell like that, but this is the reason. This is the reason why it is so important. There are even other causes also, but at least I felt like that these are the three main causes, or in fact 4, right? The high blood pressure, left heart failure when it is transudated, liver failure, protein energy malnutrition, and the nephrotic syndrome when it is exudated. Correct? Whenever so oncotic pressure when there is pleural effusion, and obviously the malignancy. When there is malignancy, it's total. So here, I'll write it over here, lymphatic. So damage to thoracic duct, right? Damage to thoracic duct. So thoracic duct damage, so what it has done, it has dumped that fluid into the pleura. Now this thoracic duct, which is carrying the fluid, it is milky, right? It is a milky fluid. So it is called as the chylomicron. It consists of chylomicrons. Chyle, that is actually the name of the fluid which is running. So it is the chylomicrons which are in lymph. And that's why when you will do the pleural tapping, you find that it is the milky fluids. So all these were the causes of transudative. And all were the causes of transudating. Any query, anything you want to ask till this point? Because from this point onwards, things are very quick and very easy to understand. Any query till this point, let me know. हाँ छलनी सर सेम है, हाँ वो सब सेम या एक्चुअली छलनी all clear, awesome. These were causes for madam pleural effusion, right? Pleural effusion. Why the fluid gets cut? What can be done? Well, we need to treat the patient. If it is glomerulonephritis, so that means you need to treat the infection. If it is infection to be treated, well, in that case, antibiotics, right? Which antibiotics? Well, we'll be going for antibiotics which are effective for the nephrotic system. If it is liver involved, then you'll be treating the body. All 5 causes. Anyway, see, just let's see this. Well, we'll be going bit quick. Still, there are some X-rays which are there. So here it is. This is the first cause, increased blood pressure, because it will be raising the hydrostatic pressure. Right? Second, left heart failure, that is happening. So that is leading to increased back pressure. And because of increased back pressure, there would be increased hydrostatic pressure into the pulmonary capillaries. Right? So fluid would be pushed out. Oncotic pressure. This is the third thing. Right? Liver failure, because liver is making proteins. Less number of protein. So less protein, that means there would be decrease in the oncotic pressure. Oncotic pressure loves water, right? It keeps the water. So that red wala heart, it loves water. But when there is no protein, no oncotic pressure, pani ko bulane wala koi nahi, water goes, right? So that is the liver failure. Person is pressure on liver, nahi. Oncotic pressure means pressure on liver. No, oncotic pressure is the pressure in any of the blood vessel. Oncotic pressure is that pressure which is inviting the water. It is holding the water. It holds the water. Holds water. Right? It is not so. It is pressure in the liver. Liver fails. Protein is decreased. Protein is decreased. So there is no one to love water. So water is no one invites the water. Water bar bhagya. Right? Because of protein in that water. Or because of protein in this fluid, which is in our case over here, is blood. Correct? Then protein energy malnutrition. कोई खाए नहीं protein तो क्या करें? Right? Body will go into the state of malnutrition. And third is nephrotic syndrome. When the protein is lost. So over here, there is less production. Over here, there is less raw material. And over here in nephrotic syndrome, there is more loss. Whatever may be the reason, but protein is decreasing in the body. So that leads to this oncotic pressure. Okay. Moving on to the lymphatics, when the duct itself is damaged. Right? The thoracic duct is damaged. So content of the thoracic duct, they are now pushed into. They are pushed into the lung. And that leads to this milky fluid. So here, in such cases, the cells and fluids and everything, right? Thoracic duct will dump the entire content. Second is inflammation. That inflammation, it can be because of infection, some bacterial infection might be there. Or whenever there is cancer, malignancy, so there is inflammation. Because inflammation as such is a good thing. Esophagus is thoracic duct? No. Esophagus is different, thoracic duct is different. Esophagus is part of our gastrointestinal tract. When we eat, right, what we eat, from mouth, it goes into the stomach. It goes into the stomach. This is esophagus. Esophagus. Thoracic duct is a part of our lymphatic system. It is a very thin duct, but very delicate. But टूटी, because it goes just near this hilum, टूटा तो सीधा वहीं पर कंटेंट डाल दिया hilum के पास. From there it seeps into these spaces. Right? So damage to thoracic duct, damage to esophagus, they both are different, totally different. This is related to GIT. Right? So there is infection, there is malignancy, and when there is malignancy, so in both these cases, inflammation occurs. Inflammation occurs because inflammation increases the blood supply. Why it should increase? Because when there is infection, so we need to call our fighters. So that's why blood supply increases. Whenever there is malignancy, right, so there are so many gundas because all those malignancy. Malignancy means what? Malignancy means that आपके घर में आके someone is staying, not doing any work and simply eating at the cost of family members. Right? This is like your office. Right? आपके office में 20 जने का staff है, and then another 10 people come and they stay into your office. They eat food of these 20 people and they don't let them work also, and then they don't do even their work. But these are the cancer cells. Cancer cells are those cells which are immature and there is uncontrolled growth. Otherwise, they don't do anything. But they are immature, so they won't be doing their function. And second, they are present, so they keep on eating all resources. And then they will call others. Right? So those cancer cells, they will make more cancer cells. So that's how it will become bigger. It is not doing anything else, but it is eating the resources. Whatever the protein, whatever the glucose, whatever the oxygen, whatever is needed for the body, they are eating. Right? And our good cells, they eat, but they do their function. Right? Heart consumes oxygen, heart consumes glucose, but in the process it keeps on beating. So that's their function. Brain consumes maximum glucose, maximum oxygen, but then is the command center, works. These cells, they are absolutely faltu. Right? They eat everything, but they don't do anything. That is cancer, right? Malignancy. So in order to fight with these cells, what body will do? Increase vascular permeability. Right? All the rapid action force, our white blood cells. Right? So these vascular permeability, and when the rapid action force comes, so what happens? All those barriers attack it, right? Straight away they go into the site where the attack is there. So that's how they go as killer cells and they start acting on that. So over here in this process, there is decreased lymphatic flow. Lymphatics obstruct ho jate hain because of obstruction. Because the priorities have changed. Now, instead of clear fluid, now all these RBCs and WBCs and platelets and everyone, proteins and everyone has entered into the scene, playing their own role, because the idea is to fight. Same way over here, when there is infection, right? The simple seedha sada infection. Say for example, pneumonia. So it is called as the pneumonic pleural effusion. So here the pleural effusion has occurred because of the pneumonia, because of the infection. And then from this, we can once again divide it into two parts. One is the complicated, second is uncomplicated. So when it is say complicated, this means the bacteria which was acting, right, which has created this infection, that bacteria has also entered into this pleural space. Now, this is bad. This is the another thing is uncomplicated. So if the pleural effusion is big, the first thing is in the ward, just put the needle, right, and then take the fluid out and immediately call to the pathologist. Those report aaye to fatafat. So this is how the hospitals done, right? When you are working in the hospital, and the phone call comes, "Kare wo patient tha na, uske in pleural fluid, it is studded with bacteria. And you know that now this is a complicated case, right? Because you need to go for higher antibiotics. Uncomplicated, they say it was a sterile fluid. Whenever we hear this, oh, it is a sterile fluid. The patient will be fine soon. So this is sterile exudate, correct? There would be red cells, there would be WBCs, but there are no bacteria. So sterile exudate in pleural space, right? In pleural space. So that is what is called as the uncomplicated. So in that there would be, say, normal pH. That means everything is fine. There is normal glucose level. So that is also, and normal WBCs count. All these are into the pleural fluid, right? In pleural fluid, remember, you have taken the fluid out, and you find that its pH is normal, glucose level is normal, WBCs are normal. This won't be the case when there is bacterial infection. Bacteria has invaded, bacteria has entered into that pleural space. And now when you take that fluid out, you know what would happen? First thing, when the bacteria enters, the fight has started. When the fight has started, the cells, they release so much of acidic content because bacteria cannot survive. So in order to kill those bacteria, our cells, they create the acidic environment so that bacteria merge. So that means pH would be decreased. Right? When the pH is 7, it is normal. More than 7 alkaline, less than 7. So it becomes acidic. So this is less than 7. It is dropping. So it is. Then in this fight, glucose is the only food which is available. So bacteria bhi khate hain because bacteria will be happy. That's why in diabetes infection occurs. Because everywhere the snacks are there. So bacteria agar jo ghusa to maje, right? He'll be eating all those glucose. So over here, this is decreased glucose because bacteria are eating. Not only the bacteria, even our fighter cells, right? Our WBCs, they also eat this glucose. There is increased WBC because they are phone karke unko bulaya, boss aa jao ladne, right? So the fight is going on, and in this fight, our WBCs, they become shaheed, right? There would be dead bodies of bacteria, unki lash padi hai, right? So this is a battleground, and that battleground is pus. So when we say that there is pus, so that pus is the accumulated thing of dead bacteria, broken WBCs, right? All those colloidal material, everything, it is present over there. So it is this, right? Pus. So the medical name is called as the empyema. So when there is pus in the pleural fluid, it's called as empyema. नहीं, PUBG नहीं लिखी. So this is empyema. Those PUBG तो कुछ नहीं. मतलब when you learn the immune system, ना, you'll find that PUBG तो एक बच्चा भी नहीं. Such battles are going on. Now for the diagnosis. Last part, the diagnosis. One, you know, I taught you this. It is called as percussion, right? Percussion. So when you do this, if there is percussion, so when there is pneumothorax, it becomes resonant. किसी ने ट्राई किया था वो बलून लेके उसके ऊपर हाथ रख के टक टक. That is what is called as the resonance. In case of pneumothorax, over here it is filled with fluid, so it will be very dull sound. उसी बलून में पानी भर के then मारना, you find very dull sound. So it is called as the dullness to percussion. In case if there is any doubt in this, na percussion में कैसा होगा वैसा, just दिमाग में रखना. When you see the patient, within seconds you, yeah, this is right. Then there would be decreased breath sounds. decrease breath sound. Because जहाँ पे पानी आ गया, wherever there is fluid, that lung is out, lung दूर चला गया, right? So there will be decreased breath sounds. This third thing is super interesting. This is what is called as the decreased tactile vocal fragments. Right? नाम जरा लंबा है. It is called as the decreased tactile vocal fragments. Now this fragments is a very fine thing. Simple. कभी ये किया है? I don't know if you have done it. You are on, मतलब हमने कैसे किया, मतलब you are on रेलवे स्टेशन, अब यार ट्रेन आ रही है कि नहीं आ रही, और कई बार वो रेलवे के ट्रैक्स पे कान रखो ना, तो दूर ट्रेन, मतलब 5 किलोमीटर दूर you'll hear the sound, because the metal conduction, principle of physics, metal conduction is always better than the air conduction. So हवा में से जो sound waves आए और ट्रेन के आने का पता चला, you just put the ear on this metal, right? ट्रैक्स पे कान रखो, you'll know हाँ ट्रेन आ रही. Same principles. It is what is called as the fragments. The technical word is called as the fragments. Right? So it is the vibrations which are transmitted. Right? It is the transmitted vibration. That is what is called as the fragments. Now over here, you'll tell the patient, bolo. Blue balloons. Right? These are some typical words. Blue balloons, in which the sound should be there. Try to speak this thing, and how the fragments is felt. Just put your thumb, put your hand over here, and then speak. Right? Blue balloons. Right? When you speak, you feel the vibration. Right? That is what is called as the fragments. Then you will be putting your hand between interscapular space, right? Behind there is scapula. So in between the scapula, just put the hand and tell the patient ke bolo. So when patient will speak, your hand would feel those vibrations. Your hand would feel those vibrations. Such vibrations, again, the principle of train. If there is consolidation, right? If there is solid structure which has come, so when the patient tells blue balloons, so your hand would vibrate. Yeah, you will feel the vibrations. But when there is pneumothorax, simple, the transmission of vibration via air is less as compared to solid. So you'll find that there is very less vibration. So in pneumothorax, because there is air. In pleural effusion, because there is fluid. In both these cases, these vibrations are decreased. Obviously, in pneumothorax, it is much decreased. And you will be feeling this vibration. Transmitted vibrations fell between two scapular region or the interscapular region. Easy? And you have to tell the patient to speak something which is low pitch, right? Low pitch, bahare awaaz, right? Amrish Puri ki tarah. So, blue balloon, Scooby-Doo, right? Such sounds. So, blue balloons and then the pitch. So, I'll just write it down. It is increased in consolidation. It's increased in consolidation. And obviously decreased in pneumothorax and the pleural effusion. Now, as such as we'll be studying this fragments is one of the very research-like topic. There is what is called as the tussive fragments. So in tussive fragments, you tell the patient, khasi khao. Right? And when the patient coughs, and then you get the vibration, which gives you a very fine idea. There is one another thing, what is called as the bronchial fragments. Bronchial fragments is that when the patient breathes, right? So when your airways are clean, you will breathe, there is no sound. There is nothing which is rubbing, right? But when the airways are obstructed, So then sound will be passing through those partial airway obstruction. So you'll find when the patient breathes, right, you'll get the vibration. And when patient will exhale, again you'll get the vibration. Similarly, when you start getting the vibration like a musical rhythm, when it is happening, you find that this is not possible by the patient. This is happening because of the pericardium. The way there is pleura which is covering the lungs, same way our heart which is working full time, day, night, 24/7 for all those years, it is packed into a, इसके लिए भी एक cover है, and that cover is called as pericardium. Pericardium. Peri means surrounding, cardium is heart. Pericardium. Right? So this pericardium, sometimes it rubs because there is यहाँ पे fluid कम हो गया ना. For some reason, fluid is less. So that pericardium, it rubs with the heart. So that is what is called as the pericardial friction rub. So that can also be felt. Anyway, those things will come in time. Next, what you have to really do is, whenever there is, this is for the diagnosis, right? Fourth thing is called as the thoracynthesis. Though we talked about it, you have to just apply pleural tap. Put a needle and take the fluid out. So take the fluid out. That's what is called as the thoracynthesis. It is also it is AKA also called as the pleural tap. Remember, senior said it. Just tap him. Tap means take the pleural fluid out. One and the same thing. So this is a procedure. This is a procedure to remove fluid because from chest wall, right? Thorax, from chest wall. It is done even in abdomen also. When there is collection of fluid into the abdomen, what is called as the ascites. Now I'll tell you slightly more important. It's such amazing. This is, yes, definitely you'll be learning this thing in final MBBS, but good to know, right? The fluid has been taken out. And in first MBBS, if you take that, yes, this fluid is taken out, matter closes. But why not to just learn one simple thing and your level will change. This is what is called as the Light's criteria. Light's. You have taken the fluid out. It is transudate or exudate. You might say that yes, looks like it is looking clean. It is transudate. Right? And yeah, friction pericardium is bad, not fatal. It is bad, definitely bad. Or if there is any, you send it to lab. In the lab, they will give you that how much is the pleural protein serum. So these are the criteria. When the pleural protein is more, so this is the pleural protein and the ratio pleural protein upon serum protein. When it is more than 0.5, that means in our body, whatever the amount of serum is blood, right? We have got the protein. Even the half of the protein reaches to pleura, it is considered as exudate. Light's criteria for exudate. Exudate means the moment it comes, you see this in the lab report, you see this, it is 0.6. Now you know that there is definitely inflammation. There is definite infection, beyond doubt, right? Just by this much. There is another on which we can speak for another 2 hours. That is what is called as the LDH, lactate dehydrogenase. So this would be another report. It's called as LDH, plural LDH upon serum LDH. So if it is more than 0.6, then also it is considered bad. LDH, stands for lactate dehydrogenase. I'll just tell you in very brief about it. This lactate dehydrogenase is one of the beautiful. Right? In fact, this is that important thing that, say, LDH, many times it is tested, you will see it's reported even into the lab reports. So it varies. As the age increases, its level goes down. But this lactate dehydrogenase, in case if anything goes wrong, so then when can it go wrong? LDH defects. LDH defects. This thing goes wrong. If this level, it is melanoma, skin cancer, multiple myeloma, lymphoma. These are all killers. Lymphoma, that happens. Testicular carcinoma. All these things. Because whenever there is LDH, rise in LDH, that means there is tissue damage. So, LDH increase, just remember it is tissue damage. So when we'll be discussing the biochemistry, at that point, I'll be going into still more details of it. Because what happens that whether it is fat, either in the form of ketones or free fatty acids, or there is protein which gets converted to amino acid, right? Or but the carbohydrates, all of them, they will finally make what's called as the acetyl-CoA, right? And this is acetyl coenzyme. It is this acetyl-CoA which goes into the TCA cycle, right? Tricarboxylic acid cycle, or it is also called as the Krebs cycle. And it is at the end of Krebs cycle, and you get tons and tons of adenosine triphosphate, which is the currency of the body. Energy is this. This LDH, right? It plays a major role. That's why, say, its level is to be tested. Just remember that this LDH, it is important from this perspective. Okay, so now we move on to these cases. The first case, watch this. Watch this. First thing first, which should strike in your mind is size of the liver. Big one, right? So, is this more than 50% of the entire chest? 110%, right? So if I take this thing as B and this as A, so is this B bigger than half of the A? Definitely it is, right? Size of the heart, very good. Size of the heart is cardiomegaly. That's right, right? There is massive cardiomegaly. And this cardiomegaly is because of the. So in this, if it is asked that which failure would you be, right or left? See this. These are CP angle, costophrenic angle. Costophrenic angles, they are obliterated. They are blunted. Right? So much so, you can even watch the fluid level. Can you watch this? See, this is the diaphragm, right? This is the diaphragm. Over here, see the fluid. Over here, that's the fluid. These are the fluid level. So that's why this is pleural effusion, cardiomegaly, pleural effusion. Even these big vessels, they are prominent blood vessels. These are the prominent blood vessels. Blood vessels, they should be prominent because of the back pressure. So that's why this is a classical case of left heart failure with pleural effusion. That's right. Watch for the second example. Several clues we will be getting in this. So many clues. What is this? Aha, alive, alive. Alive. हाँ, ये बात अलग है. Patient was in emergency. अलग है. Now there is consolidation. That's right. Lungs बस बेचारा इतना ही बाकी रहा है. On right side. This is the fluid. So this entire thing is pleural effusion, massive pleural effusion. And this is massive pleural effusion. What other findings? Here it is. See this area, right? There is consolidation. And that's the reason they'll remove this. That's the reason left heart border is obscured. We learned that. Yaad aaya? We learned that whenever there is border, heart border gone, that means there is consolidation. And this is because the lower lobe. So there is consolidation. The left heart border. Consolidation because left heart border is obscured. Left heart border is obscured. And this is the right sided pleural effusion. Is there pleural effusion on the left side? No. See, this is the angle. This is CP angle. This is the left CP angle. It is normal. It is normal. That's why there is no left-sided. Clear? Watch this. Next one. Aha, patient survive. Yes. Yes, in this comments on heart, how big, right? Well, Viva, what you asked is this is what her question is why the patient came to know about disease this late. I mean, the signs can't be detected earlier, definitely. But at times, when patient comes to you, especially in the civil hospital, right, the government hospital, that's why you get so much of exposure into those hospitals where you need to see it. Patient would come, मतलब ये question आपने जो पूछा, this question many times comes in the mind. So what were you doing for? And they will say that they will come up with a massive jaw swelling, right? Massive jaw swelling. It is so big, it is so obvious, it is this big. When you weigh, it is about 700 grams of that collection onto this mandible. जैसे कि वो इसकी भतीजे की शादी थी, फिर ये था, फिर वो था, फिर अभी बारिश का मौसम था, तो साहब हम थोड़ी देर से आए. थोड़ा देर से is how much? 2 साल. When it becomes completely intolerable, then they, and many of the patients, they झाड़ फूक, अच्छा ये दवाई ले लो, then there are some वेद, right? They say ये पड़ीका खा लो, ये चूरन खा लो, वगैरह वगैरह, and condition keeps on worsening. Conditions keep on worsening. I'm not against Ayurveda, but in some of the cases, we need to give antibiotics to the come to this case. Cardiomegaly. That's right. Many of you. And that's right, cardiomegaly, right? There is massive. But over here, can you keep it like that? पानी भर के नहीं, प्लास्टिक की बैग में पानी भरो. Just listen this. Yeah, you are right. This is 100% correct. What you wrote, what you said over here, left-sided pleural effusion. Absolutely, that is right. But listen to this. पानी भरी हुई बैग, right? And then put it on table. तो वो कैसे यूं करके बैठ पानी की बैग, right? It is correct. This is what is called as the globular heart. This is, यहाँ पे you have to visualize it. Just remember, watch these X-rays again and again every few days, so that it could be imprinted into your brain. See, this is the border. This is the border of the heart, and like this. This is called as globular heart. Globular heart is pericardial effusion. Pericardial effusion. Here it is not only the pleural effusion. Pleural effusion is there along with pericardial effusion. One of the very typical thing in this case is, but at this point of time, I'll just try to zoom it. But if you say this, it is what is called as the curly V lines. Curly V lines, also called as the septal lines. But just see this. It is in fact a postgraduate question, but because it is seen in this, can you see a line? Can you see a line over here and can you see these lines? I'll just pick this. These are called as curly lines. If you can see that, if you have developed the vision for it, these are some of the very difficult findings too. But if when you see this, मैं रेडियोलॉजिस्ट नहीं बनूंगा, ठीक है? I mean, if you become radiologist, you have to study everything. क्योंकि कोई भी पेशेंट आए, सर्जरी वाले भी आएंगे, मेडिसिन वाले भी आएंगे, गायनेक ऑब्स्टेट वाले भी आएंगे, ऑर्थो वाले भी आएंगे. Everyone will come to you. Your responsibility would be the highest because आपने बोला पेशेंट खुल गया. Right? You say that yes, there is as well operated. He will be on OT. That's fine. That's totally fine, Nirman. You are able to see that after I pointed, but honestly, update. I am removing those arrows, and you should be able to see even now when I have removed these arrows. Can you see it? Can you see that? Yes. कोई बात नहीं, थोड़ा थोड़ा भी this is fine. But if you can see that, right? अब से ये दिमाग में रखें. Whenever, very hard to identify something, but it is not so. Give me 6 months. By the end of 6 months, you'll be able to diagnose everything. This is a matter of habit. When I said that in the first class, right, I said that watch all corners. This is one of the corners which people miss. Right? So this is one of the corners. Curly V lines, they are seen over there. And the interpretation, because this is the interstitial space which is the diagnosis changes. Right? Even see the vessels. They have become so prominent. Right? Vessels are prominent in this case. And one question which you asked very correctly, that what is the difference between pericardial effusion and the cardiomegaly? Pericardial effusion means heart is normal, but the surrounding, takiya is normal, but आजू बाजू की जो स्पेस है उसके अंदर पानी. heart who is inside, right, that is okay. Heart, which is over here, heart is okay. But the surrounding is filled up with water. Now, when the surrounding is filled up with water, it will generate pressure on the heart. Right? Heart won't be able to beat that freely because this water is exerting pressure. Huh? So you are right. So this is the thing. So here it is the pericardial effusion and typical globular heart. See this. ये तो उसका भी बात है. See this. Boot-shaped name. Boot-shaped heart na dost, it is like this. Boot-shaped heart is like this. Tetralogy of Fallot, congenital cardiac anomaly. Over here, this will be. Watch this. Watch this. Jabardast pericardial effusion. Massive. Massive. That's right. Cardiomegaly nahi. Cardiomegaly nahi. This is globular heart. No? Globular. Right? So this is, and this particular case, this patient never survived. Globular heart. So this is pericardial effusion. Along with, what about the pleural effusion? Pleural effusion, both sides, correct? This, bilateral pleural effusion. Can you see anything else in this? For that, I'll do zoom it slightly. That's right, trachea is finished. But can you find gold, all these things, round, so many. यहाँ पे तो पूरा ऐसा गोल. All these are secondary deposit. This is the patient which there was carcinoma at other place, and those secondary mats they came over here. So this is what is called as the secondary deposits. Secondary deposits. Secondary deposit means carcinoma is at one place and it has spread to other areas. Carcinoma kahin pe, it is called as the primary carcinoma. And wahan se jo cancer cells bhage, they landed over here into the lungs. I'll answer this question just now. So these are the secondary deposits. Name of the secondary deposits, it is also called as it is also known as the metastasis. Metastasis. So here we are watching lots of metastasis. Pericardial effusion. There is bilateral pleural effusion on both sides. So patient's condition was bad. Fast. So why are this so black the lung? Because of that. This blackness, right? That is, see, that blackness, we are more worried about this area. Can you see the dirty appearance? As if this is for dot. These are all carcinoma. These are all metastases. Metastases are there into even the middle lobe also, but extensively high into the middle. Metastasis means this is primary. Say in this case, there is carcinoma of liver. So that's why this is called as the primary carcinoma. And when this goes to advanced level, so these cancer cells, they go into lungs, liver, lungs, spleen, bones, and you'll find. And then the appearance changes for every level. Right? Lungs में अलग, spleen में अलग, bones में अलग. So that. But जब यहाँ पे आती है तो they are collectively called as the mats or the metastasis. Mats or metastasis, or in other words, secondary deposits. Secondary. This is primary. This is secondary. Regarding this, whenever there is bilateral fusion, this pleural effusion, and you don't watch the diaphragm, don't comment on the diaphragm. You can't comment. If there is any problem in the diaphragm, so then you might have to go for ultrasound. You need to go for ultrasound. That's why in radiology, it is like jo dikhe wahi bol. That was the first principle taught by myself. You see, jo dikhe wahi bolna hai, because only that thing is conclusive. What you can't see, you can't comment, and don't try to comment, because it may lead to some bizarre results. All right. So that's it for today. Thank you so much. Next time, we'll take pulmonary. We'll take pulmonary. Yes, Vishwa also very happy. Enjoy. थोड़ा पढ़ भी लेना, but do enjoy. Take care. See you soon. Bye-bye. From the shape, cardiomegaly and globular heart, that is from the shape. So then in cardiology, I'll show you how to diagnose left atrial enlargement, left ventricular enlargement, right atrium enlargement, and the right ventricular enlargement. So when we say cardiomegaly, we need to figure out that heart is enlarged, but which chamber is enlarged? That is very important. And globular, just remember this classical shape. Let me do one thing. I am removing these lines so that you get these correct pictures. Right? So that shape. This one. Nephrotic syndrome is when जो छलनी है ना, छलनी, that is the podocytes. Those podocytes, they are damaged, right? So the water which has to filter, so instead of water, now छलनी टूट गई, right? So only the ring is there, बाकी अंदर की जाली है ही नहीं. So everything will pass. So in that, even the proteins will pass. In those proteins, they will be going on, right? That's why it is called as the protein. And most important, the biggest molecule, albumin. So albumin. All right. And I'm putting this file into our shelf. Thank you.